Very good morning. I thank the organizers for giving me the opportunity. So I'm the bridge between the clinicians and the engineers, string of engineers that are going to come next. And then there will be again clinician that rounds off this session. It's well organized in that way. I will share some of the learnings from building solutions for chest X-ray as an example for AI in radiology, solutions that we are building right here in Hyderabad. So I want to acknowledge the Nizam's Institute of Medical Sciences, Department of Radiodiagnosis, who we are working very closely with Dr. Anu Kapoor, Dr. Ramakrishna, Dr. I don't know, I cannot see them in the audience, but Dr. Second row itself, and Dr. Rajini, who are part of our annotation team, and Dr. L.T. Kishore, who is our healthcare advisory member, who is closely overseeing what is happening. So what I want to share, this particular effort in developing India-specific data sets and solution is funded by iHub Data, which currently I am heading, but at the time I took up this, I was not the head of this or director of this. So so I'll jump right into it, based on what Dr. Maheshwari Sharad has presented. Given a very accessible overview of what AI and machine learning advances. So why do we need, so given that, for example, the latest breakthrough is that you have generalist models like MedGamma and all of this, do we still need an India-specific model? Right, so that question crosses one's mind. Of course, this is commercial. There are various other solutions that are out there which are doing well. Like Cure AI is one such make in India, made for India, whatever the current slogans are. So this being adopted for variety of programs, government programs, there are many commercial installations. There are a couple of others that I know. So one major lacuna, as we go through, there are 2-3 points I want to make, which I hope you agree, and then we can embark on how to resolve this, right? So to make solutions for India specifically. So briefly, why is important for India's most critical modality, right? The workhorse for diagnostics, and it's accessible at any center, at rural centers, everywhere. X-rays, the most accessible and useful diagnostic imaging modality. And the tuberculosis presentation, pneumonia, lung cancer, these are 3 major things where India has the primary contributors of global burden of disease. Right, so that, and the first point of diagnosis is through X-ray. And if there is a way that there are models that detect, for example, lung cancer early based on indications from chest X-ray, it will help immensely. So, the current challenge is there are commercial solutions, some of them very successful, either built here in India or abroad. But there is no India-specific open imaging repository. How will innovation, how can it be driven if we do not have large-scale, annotated, right, by clinicians, vetted by clinicians? Such data set is not available. Then you will only see these applications sprout in silos and sold to you. Right, so I think for the engine of innovation is creation of these. We do not have these, and there is of course a digitization gap. The digital X-ray is still very sophisticated and available at not every hospital, especially in rural settings, and still analog or computed radiography is the norm. So there are, so it cannot be directly taken into radiology sort of AI model development. The other is the annotation bottleneck, right? So this model will be as good as what is the quality of labels and annotations that you have. Very critical. And the other is the recent Digital Protection Act. All of these put some constraints in terms of what can be used. Retrospective data, we have that at scale, and is it possible to use? There are some constraints. It is not as easy as it appears, right? So India is sitting on gold mine of data. That's true. But is it valuable, really gold? We don't know. I mean, we need to bring that out, polish it, make it available. Then it is available to make jewelry, right? So, so the journey in X-ray, chest X-ray specifically, started with 2017. 2017 was the moment for radiology, what 2012 AlexNet was for, let's say, computer vision. 2012, there's this big data set that was put out, ImageNet, that spawned a lot of applications. One of the flagship applications was AlexNet. 2012 was always marked. So before AlexNet, after AlexNet, that kind of epoch making. So in the chest X-ray, ChexNet in 2017, this was riding on top of NIH, about 100,000 labeled images that were released by NIH, and this application was built by Stanford. I think a lot of you might remember or recognize the name Andrew Ng, who has put out a lot of, so he was one of the first teams that built this ChexNet, and ChexNet followed by Torch X-ray Vision in 2019 and so on. So there is a series of applications that came. So what is the state of the art? I'll kind of jump from 2018-19 to 26. So what is the currently available? This is Chex1, right? Ignore all the clutter at the bottom, but this is a reasoning. So vision language model for chest X-ray interpretation. It's a reasoning enabled. So what it is trained on is chest X-ray. It's a question that you have given and the reasoning steps that you have taken and the outcome, what you predicted. So this four tuple, chest X-ray, the question that you have given, the reasoning steps the expert has taken, and the answer that is derived. So all these, so this instruction tuned based on this instruction data set. There's a large data set that was released along with this ChexR. Chex1 is the solution, ChexR is the data set. I'll talk about that in the next slide. So this is, so what is this capable of? This can generate reports, it can answer questions, it can, right, so the question answering, generation, captioning, of course classification, diagnosis, all of this. So this is a confluence of vision and language and reasoning, right? So three things that are, this is kind of the state of the art right now. And so before we look at what sort of data sets available, give you a brief idea, and this is sort of redundant for this audience. So this is, for example, for the first row. Slide for the rest of you can ignore. So what does a radiology report look like? It has four major components, like it has patient and exam information, clinical indications, there are findings, what is descriptive report of finding, clinical indication, why was this investigation called for? The third is what is the descriptive and objective sort of information. The other is what is the clinical implication of what is seen. A structured report like this that is on the right hand side, some examples are shown. That what happens now is that you have the image, you have the information, and in the modern versions you also have bounding boxes that tell you the location of, so you say something heart size is big, where is it? So those bounding boxes are available. If you have now this kind of annotated data, that it is possible to train such vision language models. And of course, if you give reasoning traces, it will also learn that. That is the current state of the art. Right? So that free report generation has been there for a long time. Grounded report generation means that the report, the findings are shown related to what aspect of the image. So it will tell you what is the location where these findings are relevant or used or estimated from. Right? So grounded radiology report is the current ask and what is possible with the. So the kind of data set you need just to contrast. This is a large data set, 160,000 data set called Rex gradient that has all the information as what pad chest grounded report data set has, except it has additional localization, bounding box, what are the coordinates where you see these different aspects. All that is also annotated in the data set. All right, so this is a list of various data sets that are available, except the last row, all are Western data sets, right, of different sizes. You see that number of X-rays, starting from thousands, you have 300,000, 200,000, 160,000. One of the latest 2024, for grounded report generation, I think I have impressed on you that you just, you need not only the report, but also the grounding annotations, bounding box. Such data set at a small scale, around 5,000, is available, released. And what we are attempting, right, so this is the only grounded report generation capable data set. So what we are attempting with NIMS is to create a 10,000 data set, 10,000 sample data set, constituting the top 6 pathologies that you can see. And right, so of course this needs to be expanded to include more, but 6 is what we are focusing on. This is around, we are around 60% of the way in this process. It's expected to be completed, then we will make it open data set by end of the year. And we are also building a vision language model on top of this as a use case to generate automated text report and along with the grounding. Right? So that's the task that we have undertaken. And this is grounded radiology report, probably one of the first data sets that is available for, of course, modest size. 10,000 is still small, but this will be a good beginning. There are lots of learnings. So what is the pipeline through which we are generating this? Next slide tells you the annotation workflow that we are following. This is a annotation workflow that is designed based on open source tools at IIIT, where we take the images from the hospital server, de-identify, anonymize, filter, quality control by clinicians to see this useful or not useful, and then you have the web-based tool that we allocate this work, the annotation work, to clinicians through the cloud. They look at this on their own terminal or at home, whatever, and then they go through and do the annotation. So in that sense, it's scalable. And we follow 3 annotators, 2 of them senior radiologists who do this, and there is a head more senior radiologist who would approve this. So 3 raters sort of thing. So this is important. If you want to make your data valuable, you need to see there is not going to be one reading, right? Multiple reading. What is the consensus? Where is the divergence? All of this is going to be important for claiming the value of the data as well as value for training. Right, so we are creating that. So this snapshots, I don't want to go through all of this, but this kind of the workflow, this tool that we have developed, the final idea is from this tool where clinicians are putting all the findings, impressions, and then annotating the bounding boxes showing where these findings are related to. All these are built-in capabilities of this tool, again, developed as part of this. Right now, this is chest X-ray specific, but we want to sort of extend it to for other modalities like MRI, CT, ultrasound, all of this we should. Right, so these are the bounding boxes and various impressions that are written by the clinician. And so these are some early results from this. So we wanted to check. I think by end of this year, we'll have much more results which are more extensive. So this is one example where subjects radiology, this is the ground truth from NIMS radiology. This and the med gamma, suppose you feed this to med gamma. So it does identify pulmonary edema, but it seems to miss the cardiomegaly. In this one example, I'm not saying all are like this. So we see that med gamma is of the tools that are available is the best tool, but it still has so many misreadings possible. Right? The cardiomegaly is noted by the clinician. It's a mild cardiomegaly is what the report finding from the med gamma. So these are a couple of examples, and of course I'll have within next 2-3 months as the data set increases, we'll have more sharper sort of results. So final slide. Future directions is beyond chest X-ray, that the field, if we want to deal with chest X-ray is a 2D image, right? And the 3D that Dr. Maheshwar talked about, so CT is a collection of MR. So 3D medical foundation models are coming up with multimodal, and so that, and then generalist medical AI, which is capable of this. So this is the opportunity. What a clinician does seamlessly in the mind, that we would like AI to do, combine multiple signals of different, from the reports, from the images, from the past history, from the medical knowledge. Is there a way to combine and make a generalist model? And so that's the frontier. All of this is possible. As I told you, there are 2-3 takeaway points. One is that we need to ramp up quality data sets and make them open, right? Innovation happens if things are out. There are we have a lot of talent, but we need to leverage that. We need to create these data sets. But work with clinicians. So my submission is there are at least 3 players in this journey. And this is a multidisciplinary effort. You have clinicians who steer the solution, engineers who create and build the solution, and entrepreneurs who take this into, right? You and I cannot do. There is an entrepreneur who knows how to make the deployment or adoption successful. All 3 have to work together. And I think with that, I hope I impressed on all the radiologists sitting that we are at a sort of inflection point where together we can make a difference. Thank you.